Hello everyone, good morning. Welcome to the INI-CET 2024 recall session from anesthesia. So this questions from this INI-CET November 2024 is slightly atypical. I'll tell you the reason why I said like atypical. Yeah, usually like the number of questions are 6 to 8, and here this time we got like 6 questions from anesthesia. And if you see the last 4 years, this is the first time there's no question per se from oxygen delivery devices. Since the start of INI-CET, every single paper there is a question from oxygen delivery device, whether it be HFNC or it might be venti mask, or that question is not there, and there's not a question on IV cannulas, or there's no question on capnography. And this time slightly there is a direct one-liner questions have been asked predominantly. We'll see what are the 6 questions, and we'll discuss about this. Another important thing is this time question like which is not of your standards, though you know the answer for that, but that question should have been asked in a different way. I'll discuss about those things. Okay, so the first question: which of the following propofol, etomidate, ketamine, succinylcholine? This is a very straightforward question. The IV induction agent which causes temporary adrenal gland suppression is nothing but etomidate, because of its action on 11-beta hydroxylase. So okay, adenocortical suppression it causes, and the answer is etomidate. And you see, this has been discussed in our workbook. Etomidate, it is more cardiostable agent, no effect on sympathetic and parasympathetic systems. This is where it will discuss. Adenocortical suppression in high doses it occurs, and it is temporary, and it inhibits 11-beta hydroxylase and thereby decreasing the cortisol synthesis. The similar question has been there in our question bank also, which is asked: a 54-year-old male is scheduled for outpatient surgical procedure. The anesthesiologist is considering using etomidate as an induction agent. However, they are aware of its potential adverse effects. Which of the following is a significant adverse effect of etomidate that the anesthesiologist should be cautious about this patient? And it's been adenocortical suppression again. So that is all. The beauty of this is like we got like almost like the application of the knowledge. We are able to get all the 100% of the questions from the workbook. Then the second question: an young patient with fractures of 3rd to 8th ribs is complaining of pain despite IV analgesics. What is the next best management to alleviate the pain? ADRPLEXUS block, lumbar epidural, thoracic epidural, and supraclavicular. If you see this, for fractured ribs, if they ask what is the best is nothing but intercostal NOV block. This we have been discussed. Intercostal NOV block from 3rd to 8th ribs. Intercostal NOV block is one thing which we use very good. Now, the intercostal NOV block is not there in the options. Then comes the option of applying the knowledge what we learned about. Where is the supraclavicular block? Supraclavicular block. So let's come to celiac plexus block. Celiac plexus block, where do we use? At the level of L1, and like that is used for pancreatic cancer and CA pancreas. And if the patient has chronic pancreatitis, we use this. And lumbar epidural, we are speaking about the ribs from 3rd to 8th, and lumbar epidural is also a wrong option. The supraclavicular block, it is one of the ways like how you can block the brachial plexus, used for upper limb surgeries and hand surgeries. So the answer, the remaining is thoracic epidural. By putting thoracic epidural, you can decrease the pain of 3rd to 8th ribs. This is the correct answer. If you see this in our workbook, straight at the bilateral line, you can use for trauma and post-herpetic neuralgia, and also anything over the ribs. Intercostal NOV block, that is not there. The next best is thoracic epidural. Then we discussed like supraclavicular block is a type of brachial plexus block. We discussed there's no workbook. Celiac plexus block we have discussed, like located at the level of L1, and for painful conditions of upper abdomen, CA pancreas, and chronic pancreatitis. The similar question also has been there, like workbook related to celiac plexus block, upper abdominal pain, where it has been asked and like how it has been given. Then AMBU RF40 belongs to which generation? First generation supraglottic airway device, second generation supraglottic airway device, third generation, fourth generation. This is one question. Like why I'm saying this is frankly an injustice to be asked a question this way. They can ask AMBU 40 belongs to which generation by providing an image. This question being asked without image is an injustice. I'll tell you the reason. There are like many types of LMAs, and AMBU is a company which manufactures that. And AMBU again has Aura Gain, Aura 40, Aura 1. So all these things are there, and there are many LMAs. Even like I'm saying it on record, like most of the postgraduates and even like they don't know each and everything which belongs to the which generation. But what we know is one thing: if there is only one port, it belongs to first generation. If it has two ports, they belong to second generation. This we all know about this. So, which is the first generation supraglottic airway device? If you see this, the first generation airway device has single port. Second generation has two ports. Here, see here. First generation one port, example LMA Classic. Two generation two ports, LMA Proceed. The additional port is the section. In the last examination, like in the INI-CET last session, when they asked about AMBU or again, it can easily be identified because it has an image which has two ports. Okay, that can easily be identified when this pooja is state is the second generation supraglottic airway device. Obviously, there is no third and fourth generation. You can rule out this. Then between first and second generation, like as discussed in the sessions, AMBU has three types. RA1, what is RA1 and RA40? One is like a single use device, and like RA40 is like you can autoclave and you can use up to 40 times. At this AMBU usually has only one port, as discussed. Like this LMA Classic is basically again a first generation LMA flexible, and if you see LMA Proceed is a second generation LMA. Here in this, the AMBU for RA40 belongs to the first generation supraglottic airway device, and if it is aura gain as asked last time, it is second generation. But again, I'm saying you this is way above your standards for the reason they would have asked the same question, but if the image would have been given, then it might be easier for you to answer. Like unless until feeling very sorry for all of you, though you might have got it correct, but still this is not the way how the question has to be asked in a very competitive examination. Then though the question like for the we have done the similar questions like LMA Classic, LMA Proceed, the first generation LMA CITES and all, but this is how applying the knowledge. Then very straightforward question: Jackson-Tree circuit is most commonly used for neuroanesthesia, pediatric anesthesia, or obstetric anesthesia, cardiac anesthesia. Jackson-Tree circuit is nothing but Maples and Gaff circuit. So we know Jackson-Tree circuit or JAS circuit is most commonly used for pediatric anesthesia, mostly in children less than 6 years or more, less than 20 kilos weight. This is we have discussed like multiple times. It's a very straightforward question. So which we have discussed in the class also. Maples and IPF, best circuit for children, both spontaneous and controlled ventilation used in children less than 6 years and less than 20 kilos. And again, see the question from the workbook. An anesthesiologist is selecting appropriate breathing circuit for pediatric patient. Among the various Maples circuit, which one is commonly used in pediatrics? ACDF. And we have also answered the similar question like alternate names, like what is alternate names? So there also we know about this. So this is where like we are touching upon the 100% accuracy. Then comes to the next question: which of the following is true about resuscitation in children? Compression to breath ratio is 30:2 when two rescuers are present. Adenosine is preferably given intraosseously. Chest compression should be 1/3 of AP diameter. Adrenaline is given 0.01 milligrams per kg in 1:1000 concentration. We have discussed this. See, which is true. We need one statement which is true. So we know like chest compression to breath ratio is 30:2 when two rescuers are present. So remember, we have seen this here. When there is one rescuer, it is 30:2. When there are two rescuers, it's 30:2 in adults, but in children, it is 15:2. We have discussed. So this is a wrong statement. That adenosine is preferably given intraosseously. Leave about adenosine. Any drug like we prefer by IV only. If adenosine, in fact, like we prefer to give, like if there's a central line, we prefer to give through central line. And intraosseously is a wrong statement. Then chest compression should be 1/3 of AP diameter. Here we discuss chest compressions also. In adults, it is 5 to 6 centimeters. In children, it is 5 centimeters to 4 centimeters. So it is like 1/3. Like when you see the AP diameter, it's close to 10 to 12 centimeters. 1/3 of this is close to that. This is the correct statement. And adrenaline is given 0.01 milligrams per kg. This is correct, but not in 1:1000 concentration. It is 1:10,000 concentration. When we discussed about adrenaline, various concentrations in when you're using for local anesthesia, you use in 1:2 lakh concentration. And the previous examination, they have asked about rather than 1:2 lakh, they had given 1:1 lakh. So that is it. It's not 1:1000 concentration, it is 1:10,000 concentration. We have to answer like similar things. This 30:2, 15:2 questions we have answered in our question bank also, direct assimilating questions. The similar thing, like usually they would have asked the other way. The most important change regarding the pediatrics is actually the respiratory rate. This is like 20 to 30 per minute in children and infants. This is the most important change in the ACLS guidelines, like sorry, BLS, ACLS guidelines of 2020 AHA guidelines. So this is a question which was asked in 2020, in fact, and 2021. This time they asked me slightly a different way. Again, a question from cardiopulmonary resuscitation is inevitable. Always it happens. Then comes again. This is another question like which is there similarly in our app, the Q bank, where we are touching about the compression depth, the respiratory rate, and compressions. All it is based on adults and the explanations we have about the children. Then the last question: which of the following is false statement about thiopension? Don't forget, like they're asking about the false statement. So you need that one statement, like which is a false statement, and you can get all the things correct. So redistributed to adipose tissue and muscle. Yes, this is a true statement where the all IV anesthetics, in fact, like the redistributes, like and thiopenton has some major redistribution. It distributes 90% redistribution and achieves maximum concentration in brain by intravenous injection. The name itself, they are intravenous induction agents, and they have arm-brain circulation of like 15 seconds to 30 seconds for various drugs. And obviously, the name itself, the name itself says it's a common sense, intravenous induction agents. So there's a true statement. And maximal excretion by kidneys. We'll come back to this in a second. Then lipid soluble. Lipid soluble, all IV induction agents for per se is like a lipid soluble drugs. Only then they can go on and act in the brain, in fact, inhalation agents also. So it's a right statement. Then, even if you don't know any of these things, you know about this maximal excretion by kidneys. We have discussed, like when we compared the things, like we have seen thiopenton, propofol, ketamine, the metabolism we discussed. Thiopenton metabolism is in liver, 100%, and propofol 80% liver and 20% extrahepatic, and etomidate and ketamine again in liver. So there's no way about the kidney here. Even if you know this is the wrong statement, then you will get the answer correct. Even if you are not sure about A, B, and D, you can still get the question correct. Okay. So again, we have done, so there's a question like sodium thiopenton is classified as ultra-short-acting IV induction agent in clinical practice. What is the primary physiological mechanism for ultra-short duration of action? We rapid absorption, metabolism, redistribution, excretion. Okay, redistribution we had done. This is the direct question from our Q bank. So this is how the questions have been framed. And I'm very happy to say that out of the total 6 questions asked from anesthesia, directly from workbook, like 5 out of 6. The reason why I said like 5 out of 6 and application from workbook content 6 out of 6 is we know the concept of first generation and second generation supraglottic airway devices. But the thing is, if the image would have been given, then it would have been 6 out of 6 here also. Similarly, direct from question bank, we have 5 out of 6, and application from question bank content, we are touching upon 100%. The workbook has been meticulously drafted, and the question bank is completely curated by the faculty, where we are able to touch, by God's grace, God willing, 100%, and with all our efforts to get the things done. And these are the 6 questions asked from anesthesia. Despite the questions not being asked, the important things for your upcoming NEET-PG examinations or INI-CET, like whatever it is, like you will get a question usually from touching from malignant hyperthermia, capnography monitoring, sugammadex, and IV cannulas, and most importantly, oxygen delivery devices. As I tell you, this is the after 9 exams, this is the first time you are not getting a question from oxygen delivery devices. Okay, that's all, guys. I wish you all the best. And I know, like, except that I still emphasizing the point, if the image is given, like you might have got the thing correct, and it's a gamble for that supraglottic airway devices question, but that's fine. And wish you all the best, and wishing to interview few of you after the INI-CET results, and all the very best, and good luck for the upcoming examinations. Have a great day.